Hadala is es. Atlan is de gudene lagen. Roald Helgesen Inuditiam. Florence Helgesen Johnson, Dinan Uijan. Annie Ray West, Diao Uijan. Thor Helgesen, Dichon Uijan. Diskanum de Kaede. Judy Helgesen, Diskanum Uijan. Good people, my name is Roald Helgesen. I was born a child of the Haida. My father's people are Eagle, Beaver, from the community of Haukan. Haukan, Klinquan, and Sakwan came together 100 years ago in 1912 to become the community of Heidelberg in southern southeast Alaska. My mother's people are English and Finnish settlers on the Sumas Prairie. I grew up in the community of Sitka, where my parents went to high school. I want to be really clear. My parents met and they got married, and then later on, I grew up in the community of Sitka. I didn't get that story right. I'm so proud to join you here today. It's important that I share who I am. And amongst the Haidas, there are not anybody who's orphaned. And my aunt officially adopted me as you follow your mother's clan. My aunt adopted me, and so I'm an Eagle Frog. So I'm very pleased to join you. I come to you today as the Chief Executive Officer of the Alaska Native Tribal Health Consortium. It's very exciting to share with you a little bit about what we do. But as I heard the introduction of folks who are here today, and please don't dissect me in an interdisciplinary way later, I got the impression that many of you probably know what we do, or are the people that we serve as customers or owners of the Alaska Native Tribal Health Consortium. It's amazing what we have done as a system, and I'll share an orientation to our system. I'm excited to join you as a former UA member, as I was alumnus of the University of Alaska Anchorage. I finished in December '93, but I guess that technically makes me the class of '94. And I'm sure if you look around hard enough, you'll find all of the areas I may have tripped and stumbled while I went to college. So it wouldn't take too long to uncover one thing or two. But I appreciate the opportunity to come back and share with you at UAA, as I was very proud to be a Seawolf, and I gained so much being there. So thank you for the invitation to come and share a little bit about our organization. I have a presentation just to keep me focused and on track. And if it's okay with you, and I don't appear too formal, I'd like to just continue to stand if that's all right.
And your clicker's already to go there, so
Oh.
whenever you're ready to advance your slide, you can just hit the right arrow.
Great. So let me talk about the history of tribal health in the United States. Maybe I've got it wrong. Okay, there we go. So from the 1900s to the 1970s, services that were provided for our Alaska Native American people across the United States, and specifically here in Alaska, were provided by the United States government. And policy for our Alaska Native and Native American people across the United States changed dramatically in the late 60s and into the 70s under the Indian Self-Determination and Education Assistance Act. And so from the 70s into the 98 time period, you see a time that we call self-determination. And initially in the 70s, the tribes became involved in the direct operation of our services. It began with our community health aides. Quite frankly, these are, today even, they represent about half of all of the primary care appointments and encounters that happen in our entire state each day are our health aides. They still have that type of impact and volume across the state. We began managing those programs in the early 70s, and we contracted and provided those services exactly the way the Indian Health Service had provided it before. We began to then assume management of clinics, some of them larger clinics, like in my own region of Southeast Alaska, was the Juneau Medical Center. that we assumed management of. And then as we moved into the later 80s, we dared to take on management of entire hospitals. And so for me and my region, the community of Sitka, in 1986, while I was still in high school, the Southeast Alaska Regional Health Consortium assumed management of Mount Edgecombe Hospital. And in fact, at that time then, the entire service unit. That service unit ranging from Yakutat in the north to Ketchikan in the south, actually down to my father's community of Heidelberg. So then we began to operate those programs. But I said that we operated them under contract, in which we provided those services exactly the way the Indian Health Service had provided it before. That allowed us, under self-determination, to initially provide that service under what we called Title III, which was a contract. Later on, we moved into, and you don't have to remember the titles, and I don't have any quizzes or tests, but we moved into what became Title V, which was of most importance to us. Title V allowed us to move into something called self-governance. And why that was important is as we moved into Title V and self-governance, this was no longer a time in which policies and decisions were made in Rockville, Maryland, or along the banks of the Potomac, but instead, in rooms like this around Alaska, our elected tribal leaders set policy and direction. And they could take those resources and those funds, oftentimes from different purposes, and put them together and remold them into something that made sense for Alaska. And we will talk shortly of what that looks like today, because it's pretty amazing. So I wanted to talk about the self-governance. So we talked about the Southeast Alaska Regional Health Consortium a little bit. In Southeast, we have 18 tribes that make up SEARCH. 18 separate tribes with health authority and health power. And by resolution, they hand that to a single organization. It's a consortium, really a not-for-profit corporation. And everybody's handed over their health power by resolution saying, I delegate to you as the tribe and the tribal government, that entity that then has a relationship with the federal government. I'm delegating to you my health authority to take care of our people. That's what creates these consortiums. You know them as the Arctic Slope Native Association. You know them as the Yukon-Kuskokwim Health Corporation, the Tanana Chiefs Conference, the Southeast Alaska Regional Health Consortium. You know them as South Central Foundation. All these consortiums exist around the entire state. And in fact, the tribes that make up these organizations are Route 230, I'm sorry, there's always question about a couple of them and their current status. We feel very confident it's at 229 right now. 229 tribes across the state. Half of all tribes in the United States are right here in Alaska. So these tribal governments are operating, and they have given their resolutions to predominantly 12 regional health organizations. And then there's several that are independent that are running these programs on their own. We call them our unaffiliated tribes. They're not affiliated with a regional health provider. In total, we serve about 140,000 Alaska Native American people across the state. But in some of our communities, we're the only provider of care. And in fact, in many of our rural locations, we are that provider of care, and we have sought out new opportunities as community health centers as well to make sure that we are providing services. You all come from Alaska, so this slide probably means very little to you. You already understand the geographic challenge, but what we offer here in Alaska is a health system. And you see the lines going from some of our most remote areas into regional referral centers, into then tertiary care centers. And I'll talk a little bit more about ANTHC and what our role is in there in just a minute. Usually this gives me the opportunity to talk about the magnitude, but you already know the magnitude. I don't need to share that with you. You understand the magnitude of Alaska. So who is ANTHC? Who is this group? We knew as we originally started with our health aid programs, and then we moved into clinics. And I'm not just talking about medical care. I'm talking about behavioral health services and dental services, all of these services, and prevention services, and public health nursing. All those combined into one. We started at the community level. We moved up to regional clinics and facilities. We moved up to regional hospitals. And then we moved to assume management of the entire state of Alaska. And so that you can see in 97, we were formed by Section 325 of the Appropriations Bill of that year. Section 325 formed the Alaska Native Tribal Health Consortium, and setting up a board of 15 separate members, representative of each of these regions, and then 2 representatives from unaffiliated tribes to make up our board. And this is the genius, frankly, of the tribal health system. And while we aren't perfect, boy, I could probably start writing a list of all of our challenges. The genius of this system is the people who walk in the door own the system. They aren't just customers, they own the system, and they set the policy for the direction we're going to go. If there's ever a question about who sets the policy, come join me in a board meeting. There's no question in my mind. So we have 15 members on our board of directors, and you know, they don't just sit on this nationwide board. In order to be there, they have to be appointed or elected by their region. In order to be there, they have to be appointed or elected by their council at that local level. In order to be there, they have to be appointed or elected by their people. So there's a lot of steps in between. With all that, we've had incredible longevity on our board of directors. Some people still being the same folks who were there at the beginning. And yet we've also had change. We've had a little bit of both. So we've had some great stability, and we've also had some change. It's important to talk about our vision, because our vision, as I said, comes from Alaska. Our vision as a people and what we provide every day is exciting. A lot of people talk about our mission or their mission. When we talk about our mission, talks about partnership and serving our people and working in all sorts of areas of health across Alaska. But what excites me most is our vision, and that is that the Alaska Native people will be the healthiest people in the world. And when we talk about partnership, we don't mean just partnership with different corporations. We mean partnership with communities, partnership with family and care decisions, and partnerships with individuals. And we'll talk a little bit about that. At the Alaska Native Tribal Health Consortium alone, we have about 2,100 employees. But I'll tell you, statewide, there's about 7,000 people working in the Alaska Tribal Health System that represents all these different organizations. And our operating budget is nearly $500 million a year for the Alaska Native Tribal Health Consortium. Sounds like a lot of money, but when we start breaking it down and start talking about the services, suddenly those numbers become very small. I've lost my track here in my notes, so if I repeat myself, just kick me under the table, all right? So why tribal ownership? Well, I talked about the fact that it is decision-making and flexibility for us as tribal people, not decided by, well, no offense to anybody if you're working with Indian Health or Health and Human Services, please close your ears. We're not, we don't work through that bureaucracy. We make this decision as close to home as possible. And we view this as home decisions. That we set these priorities locally, and that our strategy then is linked to our budget each and every year. That we work on the integration of primary care and family, because we know over and over again, it's been shown to us that early and regular access to primary care means better outcomes and better health status. So here I am coming to talk to you about the tertiary care hospital, and I'm telling you no, primary care is where it's at. Care is close to home, because we know in the end that's where we will achieve our vision as a people. And we want to make sure our services are culturally relevant. You might say, hey, Roald, you missed the first bullet, and that's because I think it's the most important. For us, it's easy, because the people that we serve are our friends and family. You heard that these are our people, these are our tribes, those are faces that we know and see that come through our clinics, into our offices, are our clients, are the communities that we work in for Village Safe Water and Sewer projects. These are friends and family. And if you ever lose track of that, your aunt will give you a call, and she'll say, hey, I went to your clinic today. And I said, Auntie, it's our clinic. She said, no, today it's your clinic. And so those are times that remind you and keep you grounded and centered. So let me talk about the divisions of the Alaska Tribal Health Consortium. I said that we are made up, and we, I know, are confusing to many people. And the great part about our system is ground up, not top down. So our divisions here that ANTHC is responsible for is the Alaska Native Medical Center, the hospital portion of it. The primary care portion is operated by the South Central Foundation. Let me explain that. South Central is that regional organization like SEARCH, or like YK, or like TCC. But there's no sense building two hospitals right next to each other, one for tertiary care and one for primary hospital services. Instead, let's keep one. So we co-manage that larger campus. We have a governing board that oversees its hospital operations and is responsible for assuring that we meet quality standards, like Joint Commission that was just here. And we all know that gold seal of approval and what Joint Commission means, which makes us all a little frenetic at times, but we actually did very well this last time around. So we operate the Alaska Native Medical Center, and it represents about half of our operations financially. Then we operate the Division of Community Health Services, and there, much like here, we have people who are training, literally over video conference, like our friends in Juneau and Barrow and Fairbanks today, as well as here in Anchorage. We train those health aides that I spoke about. Health aides not just in the area of medical services, but also dental health aides. We train dental health aides for their first year here on campus in Anchorage, and they spend their second year in Bethel and train there in Bethel for their second year before they go out to practice. We're also involved in health promotion activities, whether it's HIV and AIDS, or whether it's working on suicide prevention around the state, both working on injury prevention and focusing on traditional foods and that application. If I get a moment, I'd like to tell you just a little more about traditional foods. I was very excited when I was in Alaska last week. We also have a group that, believe it or not, digs ditches and puts in water around our communities. This last summer, we had 40 different projects in 30 different communities to put in water and wastewater projects around Alaska. In fact, we've just been up in Kivalina trying to help them out, as you've probably read about their water crisis in the community of Kivalina. Very important to us, as we know it has a direct health effect. We see reductions in skin infections, we see reductions in upper respiratory infections by having safe and clean water, healthy homes, healthy communities. And believe it or not, we're even working on something that I never thought as I started my track into acute care services, which was food security. That seals and deer and bear that show up with alopecia. What does that mean to us? So focusing on food security in the changing environment makes a difference to us in the health of our people. We have a whole group of folks who work in that in our Division of Environmental Health and Engineering. But not just building the water projects, but assuring that those projects are sustained. So we have a group of folks who can provide that expertise to our water plant operators across Alaska. And in some communities, we even provide some of the infrastructure at the community's request to do things like billing and collecting for sustainability. If you're going to put $3 million into a water plant, you need to make sure it's sustainable in the longest term. And some communities say, please help us with that. Some communities, that the energy costs are still so high that they have to turn that down. There's $1 billion of need in water across the state for just safe water and sewer projects, so that we have what we have here in Anchorage or in Sitka or in Juneau in every community. And we don't have clean buckets any longer, or that you have access to safe drinking water. This is still a crisis across the United States, right here in Alaska. $1 billion of need still. Then there's a group of folks who support all of these operations around the state. We call them our Consortium Business Support Services. I say support. It is a group of folks who do everything from human resource management and recruitment to supplies. If you're a small clinic in a small community, you may not need the Costco 24-pack of something. You may need one of those or two of those. So we'll stock it on the shelf. We'll buy that case live and we can sell you those smaller pieces as you need it. Or perhaps it's VA schedule for medication to reduce that cost dramatically on that schedule for purchasing. Okay, let me talk a little bit about the health of our people and why we're involved with what we're doing. We are a data-driven organization. As our boards, as our tribal leaders looked at what will our priorities be as we move forward, we don't want to do that on anecdote, and we want to make really good decisions. We have a whole group of folks who collect data and let us know what are the causes of morbidity and mortality amongst Alaska Native people. And then how does that compare against the United States? How does that compare against our history? Where are we doing well and where do we have challenges at? So we look at data to be able to say what should be our focus areas. Cancer is the leading cause of death for Alaska Native people, followed by heart disease. For us, the largest number of years of life lost is suicide, intentional injuries. For us, behavioral health reasons, behavioral health admission and suicidal ideation is in the top 10 reasons for admission to hospitals across the tribal health system. This is the type of data that we look at and we say, these are our challenges. But also, where have our successes been? Our work around breastfeeding has actually shown very good results. We've seen declines and leveling off as far as cardiovascular disease, just slight, ever so slight. And we saw significant decreases in infectious disease. We've seen improvements in our neonatal deaths, although our challenge still is that we have twice the national average in that area. So we take data and we try to form a new future, and we take our resources and focus it on that. Not just what's going to happen next year, but what's going to happen in 20 years, and that's what our board focuses on. So what we saw as infectious diseases and injuries of the 50s, 60s, 70s, and as we moved into the 80s and now into the 90s and 2000s beyond, we're now seeing much more around chronic disease. We're now seeing some of the challenges around behavioral health and the comorbidities. So as we focus on the health of our people, we focus on data and facts, not just anecdote. And what types of services do we need into the future? Here's our population pyramid. I enjoy looking at our population pyramid because we see a big group of folks who are moving into those childbearing years. So you can start seeing what are we looking at into the future. And you see the next big wave going to move into elder services. Important to know what are we looking at 10, 15 years. So if I might be the only one really fascinated by population pyramids, I apologize. But these are the types of issues I like to look at to say, what is going to be coming at us so that we can be prepared for the right types of services into the future.
Good question.
What was the top number? What was the? I couldn't tell which way that graph was going. My eyes.
So the top. I'm sorry that it's small. I really want you to see the curve, quite honestly. The top is the largest age down to 0.
Thank you.
And so what this is telling us, and then looking at against national averages, where is the ages of our population pyramid, both males and females, we're able to look at and say, okay, how do we compare against national averages? What then, looking at our morbidity and mortality, what can we expect in 10 years? Are we going to have a lot of childbirths? Are we going to have a lot of folks aging? Are we going to have a lot of heart disease? What are we seeing now, and then what can we project into the future? And this is really all about connecting it back to data when we talk about the health of our people. Does that make sense?
Absolutely.
Okay.
Got another question. Do those data include those native residents who are residing outside?
No, it doesn't, not in this case.
Okay.
Thank you for asking that question. No, not all Alaska Native people, Native American people, well, first of all, not all Alaska Native people live in Alaska, but the only data we can capture are those people who are in our system or are reporting here in the state. The fact of the matter is 60% of all Alaska Native American people, well, we represent only 1% of the population of the entire United States, do not live near a tribal health system that they can access. 60% live in very urban areas around the United States and actually don't have access to services that they have, the United States has a treaty obligation or trust responsibility for. So that's a significant challenge. I know that's a political statement. I'm not meaning to offend anybody.
Because that's a really interesting.
You're going to see that actually we're off the national average. We don't have as many elders, and so our population is growing as far as age, which is good, with a longer life expectancy. But our system has to then begin to change to address that issue. And we have a whole bunch of kids that are about to become parents. And so that's going to be a growth industry, and that, of course, is going to be exponential for us. So you have to think about what that looks like into the future. We're going to have more elders, and we're going to have more kids. So maternal child health is extremely important to us as a system. So let's look at some of the leading causes of death. So the number 1 and number 2 are actually very similar to the United States numbers, except they're in reverse. Cancer is number 1 for us, followed by heart disease, which is reverse of the United States population. But interestingly enough, we've had significant rises in cancer, although it just most recently leveled off. So what kinds of cancer? Actually, colorectal cancer has been number 1 for us, followed by breast cancer and lung cancer. Smoking amongst our people is about 43% across Alaska, and that's a significant challenge for us. Yeah, we know that tobacco is influenced most definitely in lung cancer, but there's some relation as well to colorectal cancer. You know, some of it's genetics, some of it people believe might be food, some of it they also believe might be related to tobacco use. And then we talk about heart disease, and you know some of the risk factors of heart disease. And pretty soon, rather than just looking at diseases, we start looking at lifestyles. So like me, who needs to get on the treadmill a little bit more, my Adonis-like physique, but we need to also address our tobacco use amongst our populations and why we're so involved in tobacco policy. When we talk about tobacco control, both regulation of the cost of tobacco and where you can smoke tobacco, and also not necessarily trying to criminalize individuals. What we want to do is create an environment in which it's not the social thing to do to go out and have a smoke. And by the way, for our UAA students, I do see a lot of smoking around UAA as well. So there's a challenge to all of us regarding our campus.
Can I ask a question?
Yes, ma'am.
So do you think that increase in those numbers has to do with increased screening? Are you screening more, and so you're catching those numbers more because the health system is improving?
I think you could link some of that to those issues. Our problem is our immediate effort in increased screening turned into later diagnosis in stage 3s and stage 4s, which I think we should have expected, that we were going to get a lot more 3s and 4s as we began such an effort. But we've seen colorectal screening rates for people who are over 50, have a family history within 10 years, have fecal occult blood, those types of issues. We've seen screening rates that used to be in the 27 to 37 range, now at 76% of those people who are walking through the door. And we're also starting to now begin to catch those cancers earlier. So you might say initially, but I think we were catching them too late to begin with because we didn't have some of those basic systems. Coordinated case management, we didn't have as many opportunities for, in the case of colon cancer, colonoscopies, which is the gold standard, far better than just the fecal occult blood test. You'll have to tell me again what that little card is. Again, right issues. So it isn't just been, oh, we're screening more, so we're finding more. It really is, we're seeing some numbers where we're actually finding people earlier now in the system. So did that answer your question?
Yep, it did.
Okay.
Thank you.
Okay, very good. So some of the things that we're doing right. We've seen, as I mentioned, a decrease in our infant mortality rates, but our challenges are we have a lot of falls that lead to hospitalizations, and it's not just elders, although it's quite a few elders. And you also know one of our challenges are that we're going to have more elders. So working in people's homes to reduce fall risks or dealing with slips and trips around our communities, making sure we have healthy homes and healthy communities is important because that's what's leading to morbidity. So some other areas of what we're doing right. We've actually been very good at decreasing teen smoking. But something happens at 19. You guys will have to tell me what happens at 19. The statistics show 19 to 29, the smoking rate goes through the roof. So you'll have to tell me what happens at 19. I have my own opinions, but we've been able to decrease the teen smoking rate, which is good news. But our challenge has been that we've had higher suicide rates, and that has been a challenge. And so we call that a health issue. I'll tell you that it's much bigger than health alone. That's an entire community issue as we deal with issues of multi-generational trauma and grief, as we deal with socio and economic issues, as we deal with then health issues and behavioral health challenges. All of that interrelates. It's not just a health system issue, it's a community issue. And our answers are in the community as well, by building protective factors for our people and assuring education and employment, opportunity. All of that relates together. We've done quite a bit. You heard about falls. We've done quite a bit on injury prevention. We see more people wearing their helmets as they're riding their bikes. But we still have a problem out in our western communities with falls through the ice, especially on snow machines, especially in the fall and in the spring. That makes sense, that we might have a challenge there. And so there's more work that we're doing in the area of injury prevention. But we still have a challenge in some of our alcohol and substance abuse. And it's not just alcohol, and now we're seeing new medications. And some of those medications are medications we, as a health system and health providers, put into communities. Not entirely us, but some of us, when we're dealing with difficult issues like pain and pain management, as we see people who are addicted to opioids, either both use and abuse. So what are our challenges for addressing that in the longer term? And actually we're seeing quite a bit of heroin use in Alaska these days. That's not something I'm as familiar with, is the heroin use. It was new to me. But that's what our staff are reporting to us, is that there's a significant increase in the use of heroin. So it isn't some of the issues that I grew up with in the 80s. They're even more significant issues today. So what's going right? I briefly mentioned some of our increased cancer screenings. Our challenge, though, is our cancer rates are still disproportionately high. And I mentioned that we were still catching cancers at 3 and 4, and our hope is that over time we'll be moving that down into stage 2, or we find that when it's still a very, very small polyp and it's just removed in that case, or that through early detection we're able to address issues related possibly to breast cancer. Or how about let's just eliminate the tobacco completely. So something else that we've been working very hard on is our significant shortage in health professionals across Alaska. You are health professionals across Alaska, whether you're in Barrow or whether you're in Juneau or whether you're in Fairbanks or here in Anchorage, you are some of those health professionals. But our challenge that we see is, as we have new hospitals coming online in Nome, as we have a new primary care clinic that South Central is operating in the valley, or Kenaitze we see down in the Kenai, Soldotna area, our friends in Fairbanks at Town on Chiefs Conference, as they're building new facilities, we already have shortage of several providers. On our website alone, we have 30 primary care provider vacancies around the state that we're trying to fill. In the area of dental, we have even more. As you look at our need for behavioral health, all these challenges are existing for us. Some of what we've done to meet those needs, so some of those shortages, is we've looked at our past to say what worked really well. And we find our community health aides who've been working in that medical provision of care. We've looked at extending that then into the dental area for dental health aides and dental health aid therapists, people who are providing truly mid-level dental services. Not well accepted by some of our dentists initially. You probably read about that, but it's a tried and true model actually outside of the United States that we have borrowed from New Zealand, and our president actually is down this week in New Zealand saying thank you very much for your inspiration and for taking our students for the first couple of years till our own program was operating here. But I should tell you that's a continuum. The dental health aid therapist is the highest level. There are dental health aid ones who work entirely in the area of prevention, working with our Head Starts across Alaska, going in and working with those kids, teaching about brushing and flossing. Very important work that's being done from my father's generation, where people have full mouth dentures, to my own generation, where, as Val Davidson reminds me repeatedly, we have a mouthful of metal, to our children's generation, where my daughter, like Val's kids, are actually cavity free. And it's an exciting future we can be looking at in the area of prevention. ENTHC is an exciting place to work, an exciting place to be. I told you that it's about family and friends every day. And it's never more exciting when we get it right and we're successful. Somebody has a great outcome, they home to the community. And it's never more challenging when there's an adverse outcome. At the end of the day, we have nobody to turn around and look at and say, it's somebody else's issue, it's somebody else's problem. The Alaska Native people have taken control and management of their health system. It's an incredible responsibility. But they've been focused entirely on solutions. We are funded at somewhere around 50% what the federal government would pay for its own employee to buy just health insurance, medical insurance. With that, we provide optometry, dental, we provide behavioral health services, we provide medical services at the primary care level all the way to the tertiary care level. And while we have challenges in our system, we have significant gaps that we still need to fill. We've come a long way, and we've taken those resources and doubled them across the system. By looking at ingenuity, issues of the past, opportunities of the past, and apply them forward into the future, as well as new ways of providing services every day. Focused most importantly on health being as close to home as possible. Whether it's village safe water and sewer, whether it's addressing smoking and tobacco control, or whether it's assuring that our children in the neonatal intensive care unit are taken care of. Quality for us, most importantly, is what our patients say quality is. But we also meet the highest standards of care, whether it's the Joint Commission or whether it's CARF or whether it's AAAHC. As you go across the clinics across the Alaska Tribal Health System, you will find these gold standards in our facilities because we take them seriously. Our boards take them seriously, and there's no excuse for not meeting them. The tribal health system has many organizations that work together, and they work together because they choose to work together. It is each individual tribe's right to make that decision about how health will be provided. But all those tribes come together, and they sit together with the Indian Health Service, and they use a consensus model in which everybody has to agree. It's pretty amazing. I've had the opportunity to sit there as everybody has to agree on how we move forward. But it brings that unity. And I think you will be hard pressed to find another health system in the United States. There's much we have to offer, and there's certainly a long way that we need to go. And we aren't fully satisfied yet. But we keep working toward that vision that our people will be the healthiest people in the world. I appreciate the opportunity, and I talked way too long to give me an opportunity, and I keep going and going and going. But thank you for the opportunity to share a little bit about the Alaska Tribal Health System. From my perspective, and I know I'm only one person, there's lots of folks here, but I appreciate the opportunity to share about the Alaska Native Tribal Health Consortium. Hawa for the opportunity to share with you.